Hey, we'll give people 30 seconds or a minute or so to join before we begin the presentation. I'm just going to start with some items to note here. So this webinar is presented in partnership by Trinity Health Medical Group serving West Michigan and Trinity Health IHA Medical Group serving Southeast Michigan. So you're going to hear from providers from both regions today, and you'll learn about services and practice locations near your community. Video and sound are turned off for all participants. You should only see the provider speaking. Their video should be on for you. Our providers will answer questions at the end of their presentation. If you'd like to ask a question, please type it into the Q&A feature at any point during the presentation, and you're going to find this located at the bottom of your Zoom window. Look for the Q&A icon with two speech bubbles. Note that questions are only visible to the webinar host. So if you prefer to ask your question anonymously, you can do that. You can select that option before you submit your question. In the coming days, you're going to receive an email with a recording of this webinar, as well as contact information for the presenters and any additional resources discussed throughout the presentation or things that come up in the Q&A. Again, we're recording it. There's no need to take frantic notes. You'll receive a link in just a few days. All right. Welcome to the Trinity Health Medical Group Wednesday Wellness Series. This presentation is titled Act Fast, Understanding Stroke Warning Signs, Risk, and Prevention. Our presenting providers are Trinity Health IHA Medical Group neurologist Awais El-Sarouji, who sees patients in Ann Arbor and Livonia, and certified physician assistant Bradley Havman-Gold, who sees patients in Grand Rapids. Welcome, Bradley. I believe you're kicking us off.
All right, yes, thank you so much for the warm welcome. And I will pull up the slides here and we'll get started. So there is no better place to start than with level 101 learning. So I'm going to lead us through stroke 101 here. Here in this diagram, you see a picture of a brain and a blood flow to various areas of the brain. Don't worry, there won't be a quiz on this. You don't need to know the name of these arteries. But let's talk about first, what is a stroke? A stroke is when you have damage to the brain from a problem with the blood supply. The blood supply has to bring oxygen, nutrients like glucose, in order for the brain cells to be able to function. And if those brain cells don't get the oxygen and glucose they need, those cells die. The first kind of larger category of stroke we'll talk about is an ischemic stroke. Ischemia meaning a lack of blood flow. So in this, there's a blockage with a blood vessel, and that keeps the blood flow from reaching the brain tissue itself. So those brain tissues are then starved of oxygen and nutrients and die. Conversely, the other larger category of stroke are hemorrhagic strokes. This is when a blood vessel actually bursts. Instead of being a blockage, it starts to spill blood throughout the brain tissue itself, and the bleeding in the brain causes damage to the brain tissue itself. Stroke is very dangerous. Let's talk about why that is. The brain controls all of your bodily functions. It can be language, like your ability to express yourself, get your words out, or your ability to understand others, understand what your loved one or friend is trying to say to you. It controls our movement of our arms and our legs and our face, controls sensation, our ability to feel things like pain, things like temperature, things like vibration. It controls something that is surprisingly complex, which is swallowing. And we need to be able to swallow well and safely in order to avoid things like pneumonia and to get enough nutrition for our body to keep functioning well. It controls our vision, our ability to process how our eyes are seeing things, and essentially everything in your body. So the brain is pretty important. It's a very complex organ, and therefore we want to avoid damage to it. If the stroke occurs in a region of the brain that controls a function, well, that function isn't going to work well anymore. So for instance, if we have a stroke in the speech center here, delineated on the figure, we may lose our ability to express ourselves. And I wouldn't be able to be talking to you right now to try and explain this if I had a stroke in that speech center. So you can see how it could be quite disabling. It's also can be deadly. It's the number 5 cause of all death in the United States. And as we said, it's disabling. In fact, the number 1 cause of disability in the United States. So here we're talking about things like not being able to work, not being able to do your hobbies, not being able to care for your children. So a stroke is a major cause of disability. It's very costly too. data, I'm sure, would be higher numbers now with inflation recently, but this is from an analysis that showed in a single year from 2018 to 2019, in the US, there was a direct and indirect cost of stroke of $56.5 billion in a single year. So you can see how, even from a purely financial standpoint, stroke has a major impact on our country. We'll go back to kind of some different subtypes of stroke. We said one of the bigger categories initially was ischemic stroke. And you can see in the diagram here how I have in one of the left middle cerebral artery, you can see a blood clot forming in the artery there. And that can cause a lack of blood flow with ischemia. Ischemic stroke, or stroke from lack of blood flow, is by far the most common type of stroke. It can be embolic, meaning that the blood clot traveled from somewhere else. The most common areas for a blood clot to travel from would be the heart, such as with an irregular heart rhythm called atrial fibrillation, where the top part of the heart kind of quivers and you form clots in the nooks and crannies, goes to the brain. Or if you get a clot that starts in one of the major large arteries, such as your carotid artery in the neck, that can travel up to the brain and get lodged in the brain. We call these embolic stroke. The other type of ischemic stroke is a thrombotic stroke. This is when the clot forms within the artery itself in the brain. This is more common in the setting of atherosclerosis, as is demonstrated in the diagram on the right, where you have a buildup of a lipid-rich plaque and then a clot forming on top of that. And this is more common in the smaller arteries in the brain. Now, some of you may have heard of a mini stroke. So what is that? Our technical term for this is a transient ischemic attack. So ischemic in the sense that it's from lack of blood flow, transient in that it's not permanent. So a TIA can have same symptoms as a stroke, but only lasts a short time. Through the years, medical providers or neurologists have defined this period of time as perhaps 24 hours or something like this, but we know these days we think of it less in how long the symptoms last, but that the blood flow comes back before there's permanent damage. Some people call these TIAs mini stroke. I like to think of it as an almost stroke. So you had symptoms from lack of blood flow, but the permanent damage wasn't there. So the symptoms go away and we don't see stroke on MRI. So you might think these are just symptoms that came and went. Maybe my arm was a little clumsy for a little while, but it came back. Now I can manipulate my lunch or my beverage well. I'm going to move on with my day. We're busy. But it should not be this way. We should take this very seriously. TIA may not cause permanent symptoms, but it can definitely be a warning sign of stroke to come. In fact, of people who have TIAs, up to 20% of them, or 1 out of 5, have a stroke, so permanent damage, which can have lasting disability within the next week alone. In fact, we think of TIA as being a temporary thing where there's no permanent damage, but you look at some of the statistics on mortality, and the 1-year mortality of TIA or mini stroke is up to 10%. So that means 1 out of 10 people who have a mini stroke, where we think about there being no permanent damage, can die within the next year. So we should take this very seriously. And next, we'll move into the other category where we said of bleeding strokes, intracerebral hemorrhage, or ICH. In this diagram, you can see a normal blood vessel on the left, and then over time, perhaps from things like high blood pressure or inflammation, it may start bulging, and then it starts to burst, as on the right, and you get bleeding within the brain tissue itself. So ICH is bleeding in the brain from a burst blood vessel. It's less common than ischemic stroke, but more deadly. So there's a higher rate of early death from this than ischemic stroke. You can also have where the artery starts to bulge and forms an aneurysm, which is an outpouching, much like a ballooning of part of the artery. And if that bursts, it's usually around the outside of the brain and can cause what we call subarachnoid hemorrhage. The subarachnoid space is one of the spaces between the brain tissue and the skull itself. And if that aneurysm ruptures there, it releases the blood into that space, which can cause significant problems. It's bleeding between the brain and the skull. And like I said, most commonly either due to trauma, which people tend to have a better outcome as far as long-term problems from it, or due to a ruptured aneurysm. If you have a ruptured aneurysm, it can have a high rate of death up front. And then people who do survive it have to be managed very closely to prevent delayed complications and lower risk of having long-term issues. As we talked about, aneurysms are outpouchings from blood vessel walls where they become weak. And the larger those aneurysms get, the wall becomes weaker and weaker, and you have increased risk of it bursting and causing this bleeding. So we've talked about different types of stroke, subtypes of ischemic stroke, and subtypes of bleeding stroke. Now let's try and think about who is at risk for stroke. So we think about both non-modifiable risk factors, or things we cannot change about ourselves. We'll start with those. As we age, which we are all doing, our stroke risk goes up. We also know, based on statistics, that African Americans and Mexican Americans have higher rates of stroke than their non-Hispanic Caucasian counterparts. Then if we look at modifiable risk factors, or things that we can work on treating or changing to lower risk, we have things you may be familiar with, like high blood pressure. Controlling blood pressure long term can help us reduce our risk of stroke, but if we aren't going to a medical provider and monitoring our blood pressure and treating it appropriately, if our blood pressure is always high, we have a much higher risk of stroke. Also diabetes, so if our blood sugar is high long term, high cholesterol, in particular the type of so-called bad cholesterol, LDL. Smoking is a major risk factor for strokes of all kinds. So this is ischemic stroke from lack of blood flow, but also hemorrhagic strokes, including bleeding within the brain tissue itself, or developing aneurysms and having them rupture to cause subarachnoid hemorrhage. Being inactive physically increases our risk of stroke. Having untreated sleep apnea or having our breathing stop during our sleep can increase our risk of stroke. And also, I had mentioned earlier when we talked about embolic strokes that having an abnormal heart rhythm called atrial fibrillation, where the top part of the heart quivers and doesn't empty, you can form clots and those can go off to cause stroke. Now, there are dozens of other risk factors which are much less common and rare risk factors for stroke, but these are the more common ones. So if you have questions, if you could have other risk factors, or if you've had a stroke, this is why it's important to see one of us neurology providers so we can assess for the more rare things too. And now I'll turn it over to my colleague on the other side of the state to talk about what are the symptoms of stroke and treatment of stroke.
Right, thank you, Brad. This is a topic that I'm very passionate about and I spend my career talking about, and I would like to dig more into the recognizing the symptoms of stroke. Next slide, please. So why is it important to recognize symptoms of stroke? Obviously, if you want to solve any problem, you have to recognize it. And often the patient who is suffering a stroke cannot recognize that there is a problem going on just because of damage of an area of a brain that helps with recognition. Or he can't see his face, or he hasn't looked into the mirror to see that he's having signs of stroke. So everyone should be aware of the signs and symptoms of stroke, whether you are at risk or not, young or old. So you can help someone who is having a stroke. And to make it easy, we use an acronym called BSAFE. The B stands for balance. So anytime there is a sudden onset of loss of balance or difficulty with movement, vertigo or spinning sensation, this could be a sign of stroke. E stands for eyes, and anytime you have a blurry vision, loss of vision in one of the eyes, loss of vision in half of the visual field, this should be evaluated emergently. F stands for face, obvious facial droop, when there's an asymmetry in the face, and often patients do not recognize this right when it happens. Someone else tells them that, oh, your face looks crooked today. It looks weird, or they notice that when they're eating and drinking, the food and beverages are coming out of their mouth. So often people are directed to the ER not because they notice there is a problem, but someone else recognized that their face is asymmetric. A stands for arms. Anytime you have a sudden onset of arm weakness or numbness, this should also be a sign of stroke and should be prompt you to go to the emergency room as soon as possible. S stands for speech, and under speech, it includes expressing yourself or understanding what people are saying. And often patients, when they experience a stroke, they cannot express themselves appropriately. They may be able still to talk, but their speech would be nonsensical. And then T stands for time. Whenever any of these symptoms occur, you have to call 911. Another symptom, more so for the other type of stroke, which is bleeding, a sudden onset of severe headache, often referred to as a thunderclap headache or the worst headache of your life. This also, if headache is not a chronic complaint for you, this should be also evaluated in the emergency room, and this could be a sign of a hemorrhagic stroke. How to act when a stroke is recognized. The first call should always be to 911. And the reason we always say that is because you may have a very small window where you're able to dial or use your phone or speak to someone over the phone. And you do want 911 to be that one who is getting that call, because they're the one who can respond quickly to you. And after that, you can make phone calls to whoever you want about your symptoms. But the first call should always be to 911. Also, do not attempt to drive yourself to the emergency room. Again, you may think that you're okay, but sometimes stroke can affect vision, and driving won't be safe. It can affect, it can make you weak on one side, and then you can drive also safely, and it may be danger to you or others. Additionally, do not attempt to drive others because a stroke patient can be sometimes weak and cannot walk or cannot ambulate, and they can sustain a fall, and that would only make things more complicated. Always call 911, let EMS take care of it, because we do have a system of care in majority of the counties in Michigan and outside Michigan, where they can triage patients depending on the severity of the stroke and direct them to specific hospitals that can guide further treatment, which we will dig into in a little bit. So always call 911. Do not drive yourself to the hospital. Reach out to EMS if someone else is having a stroke a stroke symptom. Why is it important to act fast? We always say time is brain. There's a famous study published in 2006 that looked at this and tried to quantify how much brain damage happened for every minute and second there is a cut of blood supply to the brain. And we found out that for every minute of a specific type of ischemic stroke, there is approximately 1.9 million brain cells lost in the brain. And the more time lapses, the more cells dies, and the worse is the injury to the brain, and the worse is the outcome. So the sooner we act on this, the sooner we restore the blood flow, the higher the chances of salvaging the brain and recovery in the future. What are the treatments available in the hospital? So anytime a patient comes to the hospital and experiencing an ischemic stroke, which is due to a blockage of a brain blood vessel, they may be eligible for a what we call a clot busting medication, which is a medication that basically lyses the clot inside the brain in an effort to restore blood flow to the blood vessels that was occluded. This medication is safe and efficacious only up to 4.5 hours. If a patient presents after 4.5 hours, unfortunately, we cannot give them this medication. It probably is not efficacious, and it carries a risk of bleeding. This is also why it is very important to recognize the stroke as soon as possible and bring a patient to the emergency room as soon as possible so they can be eligible for this treatment. There are other what we call contraindications for this medication that we have to check before. So it's always helpful if there is a medical history, or if we know a little bit background about the patient presenting with stroke, whether they're taking blood thinners or not, whether they had a previous major bleeding issues in the past or not, because this will determine if they were a candidate for this medication or not. Often when we see a big blood clot sitting in a major blood vessels in the brain, we can go in and through wires and catheters, where we start a line in the groin area, and we go up through blood vessels of the body all the way to the blood vessels of the brain with wires and catheters, and try to fish the blood clot out. As you can see this in this picture, this is what we call a stent retriever, which is a device used to pull blood clots out of the brain. And we know from many studies that whenever you restore blood flow within 24 hours of onset of symptoms, this will give the patient the best chance of recovery. In regards to other type of strokes, for example, bleeding strokes on the right side of the screen, you see a big bleed, and this can be deadly if the patient does not present to the hospital as soon as possible, because the brain is confined to a closed space, which is the skull. And when there is a bleeding inside the brain, there's nowhere for the brain to go, and the brain will start pushing on each other, and that's when herniation happens and the patient dying. So presenting to the hospital as soon as possible can change the outcome of death. But more and more data are emerging saying that surgical intervention and evacuation of some patients with big clots can also improve their outcome on the long term. In regards to the other type of bleeding, the bleeding between the brain and the skull, that is often caused by what we call an aneurysm. On the left side of the screen here, you see an aneurysm, a mushroom-shaped aneurysm. This is basically an pouching of the blood vessel, a weak point in the blood vessel that can over time grow and burst, rupture, and cause this type of bleeding we call subarachnoid hemorrhage. And when a patient presents to the hospital, we can go and with the same endovascular technique that we use for stroke, but put coils, as you can see on the other side here, put coils in the aneurysm and secure it to prevent recurrence of bleeding. I'll turn it back to Brad here to talk a little bit about the after-stroke care recovery.
Thank you very much. So I'll talk about after you've had this excellent care for treating your stroke, whether it be ischemic or hemorrhagic. What can you expect next? Because we do expect it to take some time for recovery, and it's an active recovery process. So let's talk about what that looks like. What to expect in the hours and days following a stroke. So a lot of these interventions that we were discussing are things that happen very quickly because they're also time dependent, whether it's giving the clot busting medication or doing one of these procedures within the artery. That happens in the first minutes to hour that you're in the hospital. So let's talk about after that. After you're evaluated in the ER and assessed that you're a candidate for these interventions, a patient would be admitted to a dedicated stroke unit in the hospital. We're fortunate through Trinity Health to have a lot of administrative support for our stroke care. And then in the state of Michigan, we have excellent systems of care for stroke. So hospitals have dedicated stroke units with specially trained nurses and therapists who are familiar with working with stroke survivors. If someone has a stroke, they can be expected to be checked on frequently because we want to watch for any delayed complications, if we should have any new stroke or bleeding complications. So there are frequent neurological checks to assess your language, your ability to move, your ability to feel things. All of these things we said could be affected by stroke. That'll be checked on very frequently over the first day. Also, we not only want to diagnose the stroke, but we want to say what caused it. And that will change how we prevent a stroke, as my colleague will talk about shortly. So this will involve blood work. Many times we do an ultrasound of the heart or an echocardiogram to look at the structure of the heart, make sure there's no clot in the heart. We do heart rhythm monitoring in the hospital. It might be having wires on your chest to look at your heart rhythm, much like an EKG, but in real time. And then after you leave the hospital, many times people go home on a portable heart monitor, something that's as small as just a sticker that goes on the chest for 2 weeks to look for any abnormal heart rhythm like atrial fibrillation. And then we like to do MRI of the brain. Initially, we do CT scans, which are good for telling us if there's bleeding or not. But to look at the brain tissue itself, we really need an MRI, which is that test where the person has to lie very still for maybe 20 to 30 minutes. It can be kind of loud, a tighter space, but most people tolerate it really well. And that gives us really the most detailed look at the brain tissue itself. And we can look at where is the stroke, how large is it, what is the pattern of stroke? And this can all give us a clue about what the cause was. At the time of admission, we also have aggressive mobilization and therapy. So this is not something where we have a stroke person say, oh, why don't you take a nap for a couple of days and rest? No, we have good data saying that early mobilization working with therapy can improve even long-term outcomes after stroke. So people will be seen by a multidisciplinary collaborative team, including physical therapy, occupational therapy, and speech therapy, which can look at things from two directions. And this is something patients or family aren't always as aware of, all the expertise that speech therapy has. They don't only deal with speech or our ability to articulate, but they can also help us assess and work on cognition and memory, and then also perhaps most importantly, swallowing. Because as I said, the process of swallowing safely without aspirating or having material go into the lungs is very complicated and requires coordination. So it's very common for people who have stroke, whether ischemic or hemorrhagic, to have problems swallowing, and a speech therapy can help us assess that, give our patients safe ways to swallow, which sometimes requires modifying how they're swallowing, and sometimes it requires modifying the person's diet, so thickening liquids or having pureed foods. Not always, but some people can really benefit from that to avoid serious complications like pneumonia. Then we have several days, or perhaps maybe 1 to several days of being in the hospital. And once we have our workup done in the hospital about what caused the stroke, and we've been assessed by therapy and we've ensured no complications, then it's time to leave the hospital. So where do we go after the hospital if we've had a stroke? There are several options. Kind of depends how severe the symptoms are, how many symptoms are, and then whether or not somebody can tolerate a lot of therapies. So I'll talk about the most common locations. The most common discharge is going home, which people like to be in their own home. So if we can do that and have it be safe and have a good rehab plan, that's great. In Medicare patients, about 45% of stroke patients return home and then have outpatient therapies. So that could be therapies in the home or where they go to a therapy office. And the interventions that my colleague was talking about, including the clot busting medications or the mechanical thrombectomy where you pull a clot out, one of the outcomes we looked at with that to show that they are efficacious is less disability, especially 3 months out. So it may give people a better chance of being able to go to their home if they can have one of those interventions. Another option is acute rehab. So acute, we always mean kind of short-term in medicine. This means you're going somewhere for perhaps a week or two, so not very long, but this is very intensive therapy. So this is for people who have ongoing neurologic problems from stroke that can tolerate intensive therapy. This means, in general, at least 3 hours of therapies between occupational, speech, and physical therapy every single day. So we go very intensely up front with therapy for a week or two to try and get the most recovery possible and then have a good discharge plan then, many times to go home after acute rehab. That's the goal. And about 1/4 of patients who have Medicare end up going to acute rehab after stroke. The other option is we call subacute rehab or a skilled nursing facility. So the remainder of people with ischemic stroke and Medicare end up going to these places. So subacute rehab is where you'll have some additional nursing care and some therapies. The kind of average timeline for that is being there about 3 months. But the therapy is going to be less intensive. It's not going to be 3 hours a day. And then some people need the ongoing skilled nursing, so assistance with different activities of daily living, and maybe in a facility even longer than 3 months. And then keeping in mind, people with stroke, they definitely can have and do have significant recovery, but we need to keep in mind that some stroke survivors, even after completing these courses of rehab, may still require some long-term nursing services or family support. So I really want to acknowledge here, not just the different facilities you go to, but if any of you out there have family members or loved ones who have had stroke, I want to acknowledge our caregivers and the care provided by family and friends long-term may be needed. And then we like to have follow-up in the neurology clinic. It's hard to say exactly how that will look for everyone because, again, it varies based on the system you're in and what symptoms you have and so on. But in general, we want stroke survivors to be seen up in the neurology. I have follow-up in the neurology clinic about 1 to 3 months after discharge. I say 1 month because that's a pretty good idea to see what the overall trajectory of recovery is and also follow up on some of the testing results. Like I said, sometimes we do that heart monitor for 2 weeks and we should have the result back by about 1 month out. So we can review that and see if there's atrial fibrillation or not. And then the 3 months I say because many of our stroke clinical trials where we've shown the benefit of things like the clot busting medication, the procedure to pull clots out, the outcomes they looked at were how your disability is or how impacted you are by stroke symptoms at 3 months out. So many times we'll get an evaluation then. At these visits, we want to make sure the diagnosis of stroke is correct, and we want to review the hospital course. Having a stroke for a person is a very overwhelming experience. Even outside of having the neurologic deficits, we do a lot very quickly because it's also time dependent. Like my colleague was talking about, and losing all these neurons every hour, you have to act very quickly, and it can be overwhelming. So sometimes people don't fully understand everything that happened to them, and it can be good to review that process in the clinic. We also want to go over any of these results that take a little bit longer, like the home heart monitor, some of the blood tests. And I would say probably most important is if we know there's stroke, to keep working to find out the cause of the stroke, because that's how we can tailor our therapy to prevent another by modifying these risk factors. We want to make sure that the medications are the right doses and make sure there's no side effects. And then if there are any delayed complications, we can address those too. I just gave as an example here, if somebody has weakness from certain types of stroke, sometimes they develop what's called spasticity or rigidity over time, which can be kind of painful or even lead to hygiene issues and so on. So sometimes in the stroke clinic, we can do Botox to help loosen those muscles and deal with that. After that, depending again how your system is set up and how symptoms there are, if it's relatively straightforward, the stroke survivor may simply follow up with their primary care provider, or many stroke survivors continue to follow with neurology intermittently, and it all depends on the symptoms, how frequent that could be, maybe every few months or once a year. There are some common categories of medications we use at these stroke follow-up visits. So to go over those in general, and then I'll turn over to my colleagues to talk more about stroke prevention. But we have a category called antiplatelets. The platelets are the part of our blood that stick together to form clots. And if we cut our arm while we're out, let's say weeding the garden or something, and we get on a thorn, we want to stop bleeding on our skin there so we don't make a mess, but we don't want clots to form within our arteries. So these medications keep the platelets from being so sticky. The most common one is aspirin. We also commonly use one called clopidogrel or Plavix, or ticagrelor or Brilinta. Anticoagulants, which are stronger blood thinners that work on a different aspect of clotting to help prevent clots, we commonly use, especially if we have that condition called atrial fibrillation, where the top part of the heart quivers to form clots. The older one is warfarin or Coumadin, but we have some newer medications so that you don't have to change your diet or get blood tests all the time. So the common ones used are apixaban or Eliquis, rivaroxaban or Xarelto, or Pradaxa. We also use medications to help control cholesterol. And even outside of their effects on the cholesterol numbers, they have anti-inflammatory effects on the arteries of the head and neck. So typically somebody gets put on a statin medication. Probably the most two common we use in stroke are atorvastatin or Lipitor, or rosuvastatin or Crestor. I included a couple other categories here where there are too many examples to list them all, but it's so common to need to control blood pressure that many times we'll be making adjustment to blood pressure medications, to diabetes medications, and there's more and more data coming out on which categories of diabetes medications are best for preventing stroke. And then we also need to understand that stroke commonly comes with anxiety and depression. Not everybody has those after stroke, but a certain percentage of people do, and that can really impact our recovery and function afterwards. So we usually assess somebody's mental health after stroke and address if there's any need for medications for that. And now I'll turn it back over to my colleague to talk about stroke prevention in more detail.
All right, thank you very much. Obviously, everything we do after the stroke happens is just, trying to put the fires down. The major work that we have to do is really in preventing a stroke, because once a stroke happens, we can sometimes help try to change the course of the disease, but after it happens. But how about changing the course before it happens, so we can, save more people, save more brains? So we'll dig a little bit more into stroke prevention. Next slide, please. With the main question, is stroke preventable? And the answer is yes, stroke is preventable. About 4 in 5 strokes are preventable. And the question that comes after that, how do we prevent a stroke? How can we lower the risk of stroke if we never had a stroke to begin with? We go back to the risk factors of a stroke. What brings a stroke? What makes you at high risk of stroke? There are risk factors that you cannot change. We call them unmodifiable risk factors, such as older age, which basically comes with wear and tear of different organs and blood vessels. Some races and ethnicities do have a high risk of strokes, maybe because of healthcare disparities, maybe because they have more diabetes or more high blood pressure. Also, males do have a higher risk of stroke than females. And then, obviously, if you have family history and the genetic factors they have no control of, you may be at a higher risk of stroke. But there are the modifiable risk factors of stroke that we touched a little bit briefly upon initially, but I do want to dig a little bit more in each one of those. Starting with high blood pressure. Maybe a couple of years ago, more than a couple of years, maybe when I went to med school, we used to consider a blood pressure above 160 high blood pressure. With more data coming up, we're learning actually that if you have a consistently elevated blood pressure at home of 130 over 80, consistently measured appropriately at home, then you are diagnosed with high blood pressure, and that puts you at a higher risk. And we call high blood pressure a silent killer because it's something that usually you do not feel anything if you have high blood pressure. You're normal until you come up with a complication of the high blood pressure. And the way high blood pressure works when it's untreated is that it promotes hardening of the blood vessels, also known as atherosclerosis. And then with time, especially smaller and tinier blood vessels, when they become hard, they start to shut down. Not necessarily in the brain, but this can happen also in the heart, in the kidneys, but in the brain also, and causes a stroke. And if you were to take from this presentation one risk factor that you need to fight for a stroke, it would be the high blood pressure. I'll show you at the end of the presentation some more data. Next slide, please. Diabetes mellitus. If you have diabetes, you are twice at risk of stroke compared to an individual who does not have diabetes. And diabetes affects large blood vessels and small arterioles and affect multiple organs again. And it is very important that if you have diabetes, you keep it under good control. Now, if you had a stroke and you have diabetes, we don't have data to support that if you lower lower your glycated hemoglobin or have a tighter control over your diabetes, that would lower the risk of stroke. So for all the population currently, we recommend a glycated hemoglobin of less than 7. Next slide, please. As my colleague touched on briefly, high cholesterol or the bad cholesterol, it can accumulate in the wall of blood vessels and causes hardening of the blood vessels, atherosclerosis, and in the brain and outside the brain. And cholesterol, people think that they eat their cholesterol. Cholesterol is some of it is what you eat, but a lot of it is what your liver generates. And some people have familial hypercholesterolemia just because of specific genes. So it is very important you get screened whether you had a stroke or not, and discuss the levels of your cholesterol and with your primary care physician. Majority of the time, just some lifestyle modifications will take care of your cholesterol. But often medications are necessary to help decrease the cholesterol, especially for some individuals who are at higher risk or who have a familial hypercholesterolemia. Next slide, please. Smoking. We still talk about smoking. It is a very common habit. About 1 in 7 men smokes, and smoking, same thing, damages blood vessels by hardening them. And it does not only cause ischemic stroke by blocking the blood vessels, but also it is well-known risk factor for brain aneurysm formation and rupture. And people who smoke are at higher risk of forming those small aneurysms that I showed you earlier that can pop rupture and cause major bleeding in the brain. Quitting is essential in preventing stroke. And we have a lot of tools right now to help whoever is dependent on nicotine or smoking to get rid of this bad habit. And the smoking, it's not only cigarettes, but vapes, hookahs, and other type of nicotine products can also affect the health of blood vessels. Physical activity, it is very well established now that low physical activity and prolonged sitting increases the risk of cardiovascular disease. And if you'd like, you can think about it as a pandemic now, with everyone mostly working while sitting, or sitting behind the desk for very long hours. And the recommendation is that anyone who's 18 years and above should have at least 2.5 hours of physical activity each week. You can distribute that over the week the way you like it, but this will come to maybe 30-40 minutes a day for 4 or 5 times a week. It is very, very important. And lastly, diet. And diet that is low in salt and sodium, and rich in fruits and vegetables and low fat, is proven to decrease the risk of stroke, whether you had a stroke or you did not ever have a stroke, and will help control obesity. This is a map of incidence of stroke in the world. Red is bad. Red means there is a lot of stroke, and blue is good. And luckily in the United States, we have less than 64 strokes per 100,000 people. But I do want to point out that even in the United States, you look at some states, they have less incidence of stroke as compared to some states where there are high risk of stroke. And this is not because they have different hospitals or they have different treatments. We have the same hospitals, we have the same system of care, we have the same medications. It is mainly because they have more risk factors. They have more obesity in the population, they have more smoking in the population, they have more high cholesterol, they have more high uncontrolled hypertension, specifically in this area where we call the stroke belt. And this shows you the effect of controlling these minor, tiny things that we don't feel about in our daily life, but how do they reflect on the incidence of stroke all over and reduce the risk of stroke. Next slide, please. This is a slide that shows you the risk factors and the disability attributed to each of the risk factor. And you can see that compared to all risk factors, high systolic blood pressure is the most contributor to ischemic and hemorrhagic stroke. So if you have uncontrolled hypertension, it is very, very important to touch base with your primary care physician or your stroke neurologist and get that under well control. How to prevent a second stroke? As my colleague mentioned, it is the way you prevent another stroke is by finding the cause of the first stroke. Often the cause can be coming from the heart. The heart is guilty, it's going out of rhythm, it's forming clots, and clots can go to the brain. And we have multiple different treatments to kind of fight that. Sometimes it is the carotid disease in the neck. We have to look at your carotid disease and make sure that carotid disease, is not forming plaques or forming clots and going to the brain. And to be able to identify the risk of stroke, sometimes you do have to look very carefully, and you do have to look extensively with multiple tests, and that can be time-consuming and costly, but it is very important to continue to look for the cause and touch base with a vascular or someone who specializes in stroke neurology to be able to dig further into the cause of stroke and prevent the treatment. Oftentimes, after we dig for a long time, we don't find the cause. And if we turn every stone and we don't find the cause, then we continue a treatment with medications. But you can't say that until you look extensively under every stone and seek explanation for why did the stroke happen in the first place. And that we can offer at Trinity Health Scarborough. With that, I will conclude, and we'll take questions.
Hey, excellent. So if you would like to ask a question, you can drop it into the Q&A feature, which is at the bottom of your screen. Look for the 2 speech bubbles and the letters Q&A. We already have quite a few in here, so I'm just going to jump right in. Is it possible to have a mini stroke and not realize it?
I'll answer this one. So it is challenging. Again, I go back to what we call a mini stroke or not. If we're talking about a small stroke, certainly we have different areas of the brain with different functions, and some are what we call more eloquent than others. So in other words, if we have one area of the brain affected, uh, where it causes us to lose motor control or have weakness of half of our body, or we lose our speech. It's going to be very obvious. But we have other areas of the brain that are less eloquent. So I want all of my patients' entire brains to be healthy, but I'll be honest, there are some areas of the brain where you could have a small stroke and have damage that shows up on MRI, but you may not perceive the symptoms. So this is why sometimes people will get imaging of their head or brain with a CAT scan or MRI for a different reason. And the report on there says, old lacunar stroke or small old stroke. And people can be very puzzled. They say, I never had an episode where half my body didn't work, or I couldn't walk, or I couldn't talk. And it can cause some confusion. Those people, I would argue, should still be referred to one of us in vascular neurology for the workup, because that stroke they may have had no symptoms, but the next stroke could cause major symptoms or disability. So it's worth still evaluating that small, what we call silent stroke, to help prevent something else.
So, Brad, what you're saying is if you have a test that maybe you're having done for another reason that isn't done by a neurologist, but it turns out you have had a stroke at some point, you should actually seek care with a neurologist.
Sorry, my unmute wasn't working. Yes, I would argue for that. At the very least, discuss it with your primary care provider, and they could refer you to a neurologist for further evaluation.
Okay, that's great advice. All right, is there something more specific you can tell when you're dizzy if it's a stroke versus an inner ear issue?
Yes, so this topic can be tricky. Dizziness can be referred to as lightheadedness or spinning sensation of the room, or both, or sometimes, it can be a vague symptom. But if you're having spinning sensation that is brief and happens only when you turn your head and does not bring any other symptoms, you're still able to walk, you're still able to talk, you have no weakness, numbness, chances that this is due to an inner ear issue is more likely than chances that this is due to a stroke. Now, if you're having dizziness, as in vertigo, and you cannot walk, you should come to the emergency room. If you're having sudden onset dizziness and you never had dizziness before, you never had any of these symptoms before, this is very new to you, you probably should be evaluated in the emergency room just to make sure that we're not missing a stroke. But this is the brief answer.
Okay, and can vertigo cause a stroke?
Well, vertigo is more like a symptom of a stroke. So vertigo can be due to an inner ear issue, but it can be due to the center of the brain that controls balance. And a defect in one or the other can cause vertigo. Usually, a stroke does not cause vertigo alone. There is other symptoms that comes with it, or signs that sometimes the patient does not notice, but on experience, detailed clinical exam, we can sometimes figure out, and obviously with imaging, we can have the right answer.
Okay. So there are a few questions asking about the prevention of strokes. So here's one that says, can you clear plaque from your arteries without surgery to help prevent strokes?
So,
go ahead.
Sorry. Clearing plaques without surgery, usually, if you mean by that medication-wise, there are medications that help stabilizes the plaque and make it more smooth, make it less ominous, make it less cause for a stroke. But to clear it completely, where basically you have a plaque and we do a CT scan after we give you a medication and the plaque is completely gone, I don't think so. Having said that, there are other options than cutting down surgery, such as endovascular techniques, where we go in with wires and catheters and put a stent, which pushes the plaque away from the lumen of the blood vessel and stabilize it and prevent a future risk of stroke from this plaque.
Brad, did you want to add to that?
Oh, I think my colleague gave an excellent answer. The only other thing I'll comment on is that stroke care is ever evolving. This is what's so exciting about it. It's a frontier of medicine. These interventions we have, many of them are newer over the last decade to decades. And then there are also other medications being studied that trying to look at if there's anything can help get rid of plaque. But as my colleague had mentioned, right now the medications we have really help stabilize the plaque so that pieces of it don't break off to go travel to the brain to cause stroke.
Okay, and some of the other prevention ways to prevent. So, if you've been a smoker for many years and you stop smoking, are you decreasing your chances of a stroke?
Definitely. Definitely,
Okay.
if you quit smoking, even if you smoked for a long period of time, your chances of having a stroke is not as low as someone who never smoked in his life. But the moment you stop smoking, this is when you stop the offender that damages the blood vessels and decreases the risk of stroke. Yes,
So it's never too late to make some healthy changes.
correct. It's never too
No,
late.
the sooner you quit smoking, the sooner you'll start to lower your risk. And our statistics tell us that after about 12 months of stopping smoking, so 1 year, that risk of having stroke drops in half, which is really quite dramatic. So I encourage
Wow.
people to stop smoking as quickly as possible for your brain health.
Wow. Okay. Have you seen evidence of small stroke caused by COVID?
Yeah, I'll speak to this first, but absolutely. Through a number of mechanisms which are still being studied. And we've also noticed it kind of varies from variant to variant of COVID. But we do know that COVID increases inflammation and has some effect that increases platelet aggregation or increases the tendency for the sticky part of our blood to stick to each other and cause blockages. So, yes, we do see people who otherwise don't have quote unquote stroke risk factors who have stroke in the setting of COVID.
Okay. Are stroke symptoms different for females versus males?
Um, I don't think so. Stroke symptoms depends on the location of the brain that is affected, basically, and usually it depends again on what part of the brain um, is having a cut of blood supply.
Okay. Do you recommend taking an aspirin a day to help prevent stroke?
There are clinical trials that looked at that. If you never had a stroke before, even if you have some risk factors for cerebrovascular disease, it does not seem that aspirin significantly decrease the risk of stroke in the future. And that's why we haven't been recommending uh, aspirin for stroke prevention if you never had a stroke in the past, even if you are at a little bit of a higher risk, like if you have diabetes or if you have high blood pressure. We do not recommend routinely aspirin to prevent a stroke.
Okay. Sounds like something you should talk about with your primary care physician at least.
It's very good to review that with your primary care provider. We talk about primary prevention, which is preventing your first ever stroke versus secondary prevention. So if you've had a stroke, preventing a subsequent one, in which it's more clear with aspirin. But the area of primary prevention, there's less evidence, although you can discuss with your primary care provider. I would encourage you really to focus on, however, modifying any of those risk factors. So if you have high blood pressure, work closely with your primary care provider to make sure you're hitting those targets, those numbers that my colleague talked about. Make sure cholesterol is under control. Make sure you're staying active and eating a healthy diet. For primary prevention, it seems it's less helpful with a medication like aspirin or antiplatelet effect and more about addressing these other risk factors.
Okay. Would you consider tingling in the hands and feet or numbness occasionally in the corner of the mouth to be signs of stroke?
So usually a stroke would affect one side of the body and not both sides. Having said that, if you're having such symptoms and have been recurring, it is important that you touch base with your physician and probably get a referral to see a neurologist. Because there are other etiologies for such symptoms that may need to be looked at, not necessarily stroke, but other etiologies.
Okay. What let me see, sorry. What impact does untreated sleep apnea have on your risk for stroke?
So,
So
untreated sleep apnea increases your risk of stroke in several ways. We know that people who have untreated sleep apnea may have higher blood pressure overall, which increases risk of all types of stroke. We also know that it kind of puts more stress on the heart as well, and eventually can cause parts of the heart to kind of stretch because when you're not breathing, there's more resistance in the vascular bed to the heart pumping. And in people who have untreated sleep apnea, there's a higher risk of atrial fibrillation or that abnormal heart rhythm where you can form clots in the heart that can go to the brain to cause stroke. So these are a couple of ways which are clearly established how untreated sleep apnea increases your risk of stroke.
Okay. At what point can you determine that the effects of a stroke are irreversible?
So usually we say um, up to 24 hours, there is a chance for some reversibility depending on the stroke. And we do have a way of imaging the brain. We call it advanced imaging, where we try to figure out which type of the brain is, which part of the brain is already unsalvageable and completely dead from the stroke, and which part of the brain is still salvageable and we can do something about it. Other way to figure that out is, aside from imaging, is based on symptoms. Usually, the more severe the symptoms, the more injury to the brain, and the less severe the symptoms, the less injury to the brain. But each case should be studied individually, and decision on treatment should be made individually.
And then
Okay.
how patients experience their symptoms. I mean, here we're talking about the reversibility of stroke on a tissue basis, whether or not you have permanent damage or if there's an intervention that can be done to bring blood flow back. But I also just want to remind people that after stroke, we can have significant recovery. So there's some neuroplasticity or ability of the brain to heal. We also have the ability for other areas of the brain to take over some function. So we know different deficits have a greater or lesser likelihood of somebody recovering that function in their body. For instance, weakness, depending on the location, somebody may get strength back. Um, and we typically see a pretty quick functional recovery if it's going to happen within the first week or so and up to a couple of months out. But I want to encourage people who are stroke survivors, even after that, continuing to stay physically, mentally, and socially active. You can continue to get improvement in stroke symptoms up to 12 months or even more after stroke. It's just the rate of recovery of symptoms slows down at that point, but you can still have improvement. So stay active, stay optimistic. You can recover with stroke.
Okay. We just have a couple more minutes left. I'm going to try to get through a few more questions here. Why does heart fibrillation increase stroke chances?
So the way AFib works is that the heart goes out of rhythm, and there is some shaking in one of the chambers where blood is not pumped out, but rather there is an environment of blood stasis, and that when blood sits down, it forms clots, and then suddenly the heart goes back to normal rhythm, and all this stasis blood that includes clot is pumped out of the brain, out of the heart into the brain and other tissue, and this is how AFib causes a stroke.
Okay. Are there certain types of strokes that are more common in women than in men?
I don't think there is a difference in the presentation of a stroke between men and women. Now, there is a subgroup of women, maybe younger ladies. They maybe have a higher risk of stroke because of autoimmune disease or more common in ladies and things like that. But in terms of stroke presentation, the presentation can be similar between men and women.
Okay. Can you talk about the impact that stress can have on a stroke? So, what percent of stroke symptoms may be related to an increase in stress in one's life?
Yeah, this is a really interesting question, and I think an area of interest and research out there. We do know that having increased stress in your life does raise your risk of stroke, and probably in multiple ways. If we have higher stress, we may have higher blood pressure. We may have higher cortisol levels or increased inflammation in our body. And especially if we have acute stressful response, we can have a sudden increase in our blood pressure, although sudden, not even just long term, and that can have a risk of having bleeding in the brain. So stress most certainly contributes to a risk of stroke. Right now, there's not a lot of clear data on all of the ways in which that works or the best intervention for that, but we do know that stress plays a role in stroke. We also know it's distressing to have neurologic symptoms. So it's very common where we have people who come to the ER with stroke-like symptoms and are also dealing with stress and anxiety from those stroke symptoms themselves. And we want to make sure that we are treating the whole person, the whole patient, and following up on that too, and making sure we're paying attention to someone's stress level and mood.
Okay, I have one more question. So can you talk about the genetic factors? So if our strokes hereditary, as in if my mother or a sibling has one, is that something I should be concerned about?
So there are some genes that can be transferred through families that can cause stroke. Majority of those are autosomal dominant, and if one of the family members is diagnosed, the rest of the family would know. Having said that, this is a very minor percentage of people who present with stroke. In regards to if you have a family member who had a stroke, especially if they had a stroke at the age above 65, you might be at increased risk of stroke. Having said that, it's not necessarily that you're going to have a stroke, but you are at increased risk, and you do have to pay more attention to those risk factors that we talked about and try to keep those under control so you kind of prevent a stroke. But it's not a direct association for if your mom had a stroke, you're going to have a stroke, unless you have a specific gene that transfers through family, and usually families knows about that.
Okay, so we are at time, or just a moment or two over. Thank you both for being here today and discussing this topic for Stroke Awareness Month. We appreciate you being here, and we appreciate our community across the state for joining us from both West Michigan and Southeast Michigan. Look for an email in the next few days with a recording as well as links to contacts and locations on both sides of the state. So thank you again for being here, and I hope you guys have a great day.
Thank you.
Thank you all.